Hi, I'm Andre Bausch. I'm one of the managing directors of Dr. Jean Bausch GmbH & Co. KG. Since 70 years, we support dentists all over the world with occlusion test materials. One of our latest additions is the OccluSense system for digital occlusal control. For our today's talk show, we invited users from different countries to discuss the benefits of digital occlusion. We are also very pleased to welcome our audience, practicing dentists from the north of Cologne. After achieving her Bachelor in Biomedical Science at the Queen Mary University in London, she studied dentistry at the University of Cologne. Since April 2023, she works as a dentist at the Polyclinic for Dental Prosthodontics of the University Hospital in Cologne. Please let me introduce our host, dentist Mina Niknazemi.
Hi, our next guest came all the way from Bhopal, India, and she maintains 2 private dental clinics over there. Her focus is on aesthetic, restorative, adhesive, and minimally invasive dentistry. She holds a BDS degree from the Government College of Dentistry in Indore and a postgraduate certificate in aesthetic dentistry from New York University. Please welcome Dr. Rumpa Wig. There's something missing. No, it's it. I'm so sorry.
I have to go.
Yes.
Yeah. No worries.
Oh God.
It's okay.
He studied dentistry at the Johannes Gutenberg University, Mainz since 1997. His dental office is located in Bonn, Germany, and between 2014 and 2016, he lectured functional diagnostics at Vienna School of Interdisciplinary Dentistry with Professor Slavicek and Professor Sato. Please welcome Wolfgang Seuser.
Thank you.
And lastly, hi, but not least, connected from Sao Paulo, Brazil, is our final guest. She currently works in a private practice with a focus on functional analysis of occlusion and oral rehabilitation, holding an MSc and PhD in stomatology and oncology. She's been working in the care and oral rehabilitation of oncology patients for more than 10 years. Together with Professor Emilia Zanatta, she's responsible for the course Functional Analysis of Occlusion. Welcome, Dr. Juliana Ebeling. Hello. Welcome. So.
Hello.
Hi.
I'm sorry.
To start off today's discussion, I just want to start off with a short question about OccluSense and your experiences with OccluSense. And I know that we have prepared a couple of cases by our experts, which we can happily discuss within the discussion today as well. So we're going to start off with a quick video to introduce OccluSense for the people who aren't familiar with it yet. You can see maybe a little bit staggered. This is the view that you have on the iPad, where you're able to enter the details of the patient. And this is the OccluSense handheld, which can connect to the iPad and gives a wireless connection for you to use freely on your patients. You have the opportunity to select different modules via the iPad and also the handheld itself. And here we have a quick case example how the sensor is inserted into the handheld. And the recording is started by inserting the sensor into the patient's mouth. You then give your system a couple of seconds to just transfer all the information over to the iPad. It gives you an OK. And you're then able to track any movement on the iPad as well as inside the patient's mouth, because the sensor also gives off color markings, just as you're used to from your occlusion papers and the foils that we use. You can see a lot of different color coordinations. I can invite you to the different webinars that we offer to find out more about what they actually mean, but it's just for you to kind of see what the OccluSense reading looks like. And it all comes in the nice little case. Okay. Right. So we are actually going to start off with our first case.
Okay, thank you, Mina. And thank you everyone here who have taken out the time to be with us here. Namaste from India. Namaste. And thank you. And I can see that the right side of the mandible of Bausch is more loaded than the left side. Right? So, okay, so with that, yeah, it's good. We need to balance, and the balancing is what we can see. So here I go, sharing my experience with OccluSense, and it's like for me, I use it in my routine, regular dentistry. Whatever case I do, it can be indirect restorations, direct restorations, implants. I don't do the implants myself. I get an implantologist to do. Ortho, I get an orthodontist who comes. But everything, whatever happens in the clinic, my husband is an endodontist. He just peers through his microscope looking for the 5th canal and 6th canal, and all that happens. But I use this tool to see what is before and what have I done after, so it allows me to see. Like Mina explained about the system, about how you can see those recordings on the iPad. I can see it directly, my patient can see it directly, so it's a beautiful communication scheme that starts off with the patient. So without further ado, let me take you through my case 1. She is a female. She suffers from celiac disease. Now, celiac disease means immune reaction to eating gluten. Her diet is very, very compromised, and over time, once she starts eating, it creates inflammation that damages the small intestine linings. And malabsorption of some nutrients and medical complications ensue. Now, that's medically. Let's check dentally, and that's how she looks because she's compromised with her teeth. And she had come to me about 10 years back for implants on her posterior teeth, but she was not the right candidate. She's a chain smoker. Chain smoker. All right, so I couldn't do the implants on her. Right now, dentally, if you see, she's got a Kennedy class 1. Anteriors are there, posteriors are missing. As such, she cannot absorb most of the food. She can't chew properly. So the best way I thought I could help her, first I took her pre-recording with OccluSense. I needed to know where the high points are, what is happening, and how best can I give her the replacement teeth, what I am planning for her. So that is the first, and that is, if you can see, I've inserted it, and yeah, it's okay, good to go. And here is her pre-recording. So this, if you can see, her most of the first contact are on the canine premolar region, because she obviously doesn't have posterior teeth, right? So now what happens here, I press this again to, yeah, there it is. So you can see her, most of the contacts are in the anterior canine premolar region and the posteriors are touching to the gum tissue on the upper, on the maxillary, because mandibular she has teeth. Mandibular she has some old crowns which also needs to be fixed, but there it goes. Then we decide to give her a window denture for better retention. So once that is done, here the denture has been given out and then I take a post recording. Now here if you see the post recording, now the contacts are slowly going towards the posterior. It has, and if you see this orange and green quadrant, that means the pressure level on the quadrant which the OccluSense shows us, quadrant wise, you can see 1, 2, 3, 4, the quadrants, it means it's balanced. Right now it's good to go. So with that, and of course a little bit more adjustment on the artificial teeth on her denture, and that's how we could give her, and she comes regularly for a checkup. Right now she can chew, she can eat, she's good. Health wise she's good. Presenting you case number 2, male, 64 years. He's got a deep bite, heavy bruxa, and main problem is not him. His wife brought him to the clinic stating, I cannot sleep due to the grinding noises he makes at night. All right, so we take him in and that is how his bites are. You can see most of the contacts right now are towards the 7-8 region on the right side and a little bit towards the 6 where he has a deciduous retained E actually. He doesn't have a permanent tooth there. So most of his contacts are kind of hitting on the anterior zone. And dentally if I check, you can see those deep bruxing bite marks here, and the upper 8 has got a crack. So what I do there, I have drawn the line myself, because what I intend to do later on, I have done it, I show it in my restorative cases. I have filled up the crack with the bioactive material and it's going good. Just dig a little with the burr, fill up the bioactive material which discharges calcium phosphate and fluoride, and it kind of good to go. But that's not the topic now. So here if I can show you the cracks on the premolars. The 6 and 7 had a nice bruxing mark, but this you can see the deep cracks and the abfraction lesions on 45-44. So that's how the patient is, and here I rehabilitated this patient with Rehasplint. Rehasplint is one size fits all, very convenient to use. Don't have to do any adjustment, anything, it's just ready to use, take it, wear it and go. So what I did was, my program for the patient was for 3 months, daytime wear 3 to 4 hours per day. Technically it's a nocturnal wear, it's actually a nighttime thing. But if it is 3-4 hours, the patient can be driving from work to home, home to work, and it was convenient for him rather than being at night. So I changed it to day wear. That's fine. So that's on Rehasplint, and then this is the post Rehasplint after 3 months, and there if you can see the recording, again the quadrants show that it is balanced, it's green and yellow. Red means yeah, there's more pressure there, as Mina described during the OccluSense, and Dr. Seuser will be taking it in much better details. So here if you can see, now his posteriors are in contact, the anterior hit has been reduced, so I can see what is happening now. And this is the protrusive. In protrusive also you can see, yes, the pressure is more on the anteriors, it is about 55 to 54% that is being shown. So all these recordings, how did they help me to calibrate him later on? I mean right in this sitting, but later on. And this is the lateral protrusion left, and you can see that after we do the lateral protrusion to the left side, and that's the contacts first, and then this is the lateral protrusion right. Again the first point contacts, which has a significant difference with the adjacent contact, that's what the red marks are on. And that is the lateral protrusion, right? And with that, here are the sliding movements for the same patient. So keeping all these records where I can see, my patient can see, his wife can see, everybody can see. So what happens here, based on all this, I calibrated, I selectively contoured the posterior teeth on the cusp slopes, not the cusps, just to give an even balance to achieve between the two sides. Patient says, I feel much relaxed and the pressure sensations on my teeth have kind of eased off. Of course, because the temporalis masseter, the main muscles, they are at ease, they are relaxed right now. So he's feeling much better, but the main feedback I got was from the wife. Thank you, doc. Was amazing to see his jaw movements on your iPad. Something that happens inside our mouth is replicated on screen right then. Wow. And I'm sleeping very peacefully at night. Ravi, that's the patient's name. He doesn't make grinding sounds anymore. And now I'm going to give him the second reha splint for the next 3 months. So that is the plan. Splint, I'm going to give him later on. Once he's through with the 2 reha splints, then I plan to give him an occlusal splint. But that comes later. First, I need to relax his muscles. So this was my TP. TP means treatment plan for this particular patient. Case 3, she's a 23-year-old. She belongs to the erstwhile royal family in Bhopal. And she is in London right now. She's pursuing her business management from there. But whenever she comes for a holiday, she's like her parents, everybody are my regular patients there. So simple case, 47, you can see there was a pit and fissure done long time back, and with her chewing habits and all, that's gone on 47, fine. And then I restored this with restorative called Activa, bioactive. And then on 36, she has a cuspal defect. Like there was an old filling which is fractured, but I did not want to remove the full thing. By nature, I'm very minimally invasive. So what I did here was, this is the shape of the problem that occurred on her 36. So here I just filled it up with a self-etch bond. I didn't etch, just a self-etch bond and a flow. And you can see there the first layer I have put on the cusp, and this one is the completed one. So here, and then I do the recording after I have done the restoration. I didn't take a pre here. I wanted to restore her teeth first. So that's, she's sitting on the chair. And this is just after the restoration. I have not touched the burr, just trying to check where all I need to go with my contouring burrs. So this is just after restoration, and you can see that her main contact hitting are on the 7-8 region on the right and on the left side too. And she has more concentrated bite on her left, left quadrant. You can see that zone, the more lights are hitting there, the red lines. This is after contouring and finishing. Once I checked where all I need to go, because I can see, it allows me to see the cusp, it allows me to see where I need to go. It's not a blind procedure anymore, you know. So this is what helps me doing all my regular dentistry with OccluSense. It is like a very needed tool for me now. And originally, I mean, before I've heard Mina, I have heard Dr. Seuser, I was a little scared. OccluSense, digital, man, should be complicated. I was very apprehensive, I'm telling you very honestly. But once I went into it, it's like this is a tool I cannot do without. It's for every case, anything you do, post-endo, pre-endo, restore it, check it out, check the bite. And since you can see where it is going, and as I said, this is not occlusion, it is like occluding, because occlusion is the finale, where it's all MIP, the maximum anticipation, but this is going inside, correcting the obstacle race in between, and then meeting the cusp to fossa. So it allows us, all of us, to see that in toto. So that is how this tool helps me. And this is, this right after contouring, finishing. And what she says, she's 23, so she happily calls me, hi auntie, no pain, no sensitivity, teeth doing well, thank you, bite is very comfy, and I could see my jaw movements on the iPad, wow. So that's her. So with that, thank you, and over to you, Mina.
Thank you so much. That was a very, very nice summary of all the times when you can use OccluSense for. So thank you so much for sharing all your valuable feedback and your experiences with us.
Thank you.
And yes, I believe we have 2 more experts who have a couple of cases prepared for us. I'm going to pass over to the next expert to present their case with us. Thank you very much.
Thank you, Mina. And first I'd like to thank for the invitation and thanks for being here, talking and discussing with us about that. So my presentation is first about the first functional view. So if we had our patient in the first appointment, we just take a close look on every tooth. We just regard the gingiva, we looking about the periodontal state, but we also have to take a look on the bite situation. So normally we have this called ICP position. This is basic information, just maximum contact of the teeth. But of course, we all know that there are lots of structures and systems surrounding that and influencing that bite position. So some of them, of course, the skeletal measurements, we can have a class 1, 2, or 3, we can have a low angle, high angle case. There are several things that influence that ICP, that bite. Of course, the muscles have a very strong influence of what is going on if we bite together, and the masticatory muscles are also very connected to the limbic system, and so to stress management processes. And of course, our joint and the anatomic situation of the disc, of the ligaments, and all these structures influence this bite situation. So for me, it's not that ICP, it's more an individual adapted position that we have. And so we have to take a look, is that position a right one? Or are some problems joined by that? And the first view we can take is that screening test. We can do it very quickly. We do a mouth opening, patient will do a mouth opening, and we can take a look if the mouth opening is wide enough, if we have some deviations to the left or the right side, if we have some clicking or other joints, other movements in the joint. We can have a quick palpating of the main muscles here, and can take a look on the situation in the dynamic processes, and we can hear the sound of the closing. Yeah, but these last 2 things are a little bit basic for this bite situation, to take a closer look on this bite situation. And so, okay. And so Professor Slavicek, for checking the ICP position, developed this so-called occlusogram. He used a special wax, and we put it here in such a holder, and we can do some situations, we can provocate some situations and let patient bite in some situations that we would have. Yeah. First of all, he's doing some ICP. He just offers to close the mouth. Then protrusion, retrusion. Ask the patient to go front and back, and of course the medial left, medial right, and a bruxing thing. And we will have this things we can see. So the wax is perforated on some in some special patterns there, yeah, and we can take a closer look on what is happening here. First of all, maybe in ICP. Similar to that, we can do it meanwhile with the OccluSense system. It's mainly the same thinking about that. We can check the ICP bite position so that we not only have these impressions here to take a look on, so we have the whole process of protrusion, we have the whole process of ICP, we have the whole process of the lateral movements, and this is a little bit like a super slow-mo to see what is happening. Yeah? We can exactly see if there are some primary contacts from where the patient is sliding to another position. So this is first ICP, and then the jaw is going to the left side. This is the same to the right side. First ICP, then moving to the right side, and some proctoring movement. And this occlusogram is surely a fine way to have more information about the bite situations, but you must document it, you must photograph it, yeah? And the OccluSense has the advantage that you have a very nice documentation, yeah? And it has the advantage that you have more information about this process, what's going on, yeah? Because on the wax you only see the result of the movement, yeah? And on the OccluSense you see the whole process of going to that position. And of course you can choose some typical positions that you like to take a look on if you are if you want to take a closer look on these situations. And you can overlay this both things. You can take a look. This is what Professor Zapata did in Brazil. He overlaid this occlusogram with the OccluSense program. So I have one example for this. This is a patient, young patients coming for the first appointment, and she is very proud of her teeth. She told me she had no problems. All teeth are very fine, no caries, no periodontal problems. Her husband is grinding and clenching, but she didn't. She told me. She's very proud on her teeth. But if we take a closer look, we see these marks here on the number 2. We see this here. There was an attraction under the gingiva. Yeah. We see here on the number 4 a severe bone loss and also periodontal problems. And on the other side, on the right side, it's the same. So, and now we can take a look with the OccluSense what's going on if she's closing in ICP position. And first thing is, if we take a look on this here, we're seeing that there is a very steep front situation there. Yeah? She has a very steep front situation in the upper jaw. And as we take a look, first contact here is in the front situation, and then she's moving in the ICP position. Yeah? First contact on the front area, and then on this. And if we take a look what's happening if she is going here, there is this gingiva problem here and here. We have some enamel cracks here. We have these abrasions on the number 3 and on the number 2. And if we take a look what's happening, if she is moving to the right side. We see here in the pictures that first the number 3 is guiding a little bit, but then the main contact is here on the number 4 and on the number 5. So that will cause the problems here. Okay. That are the problems that she had about this position here. I would expect to have a much higher level here on this number 4 because there is so much damaging here, yeah, first of all, but there isn't. Can you imagine why? You don't have so much as expected. If you see, there must be a very high column here on this number 4.
Yeah.
But it isn't. Mm-hmm. It's because this number 4 is moving a little bit. Yeah. So he's already some periodontal problems. Yeah. And he has he can move a little bit more. Mm-hmm. Yeah. And so you didn't have such a high column here because the tooth is moving. Yeah. Mm-hmm. And this is one thing we have to think about if we're doing and if we regarding this. Yeah. If you have some loose teeth, yeah, they won't give you such a high level there on that side. Okay. Yeah. And so this is the thing that perfect occlusion, that a perfect bite, yeah, isn't that, yeah, and I think that's my point to say we have to take these look on every patient who's coming in our office, yeah, because if you have to treat her, yeah, you will fail. You will have some problems, yeah? If you do a filling on this number 4 or something else, that will be very problematic here, yeah? And it's very fine to have this documentation, yeah, before you start, yeah? And so this was the same here. Patient understand much better if you show this on this way, maybe with one photo or next photo, that there is a problem, yeah, and there should be done something else. Okay, thank you.
Thank you so much. Very good presentation of the case. Thank you very much, Mr. Seuser. So now that we've heard Mr. Seuser and Dr. Wig speak about their experiences and their patients from all over the world, we also have a final country we want to visit. So let's go to Brazil, to Dr. Ebeling, who we are happy to have over video conference here today with us.
Hi, everyone.
Hello.
Hello.
I have a little delay from our sound, but I hear you.
We hear you as well.
Okay, thank you. So let's start. So I would like to show you a case where I used OccluSense to help me to take some decisions and in different phases of the treatment. This patient arrived to me with a high teeth sensitivity, since she had this erosive damage for a reflux, and I needed to offer something to control this sensitivity, but to appropriate for appropriate treatment for this case, I needed to do an orthodontic treatment to put these incisors in a better place for a better aesthetic result, and we need to solve this crossed bite here on the left side, and it took almost 2 years for this treatment. So at the first moment, to control the sensitivity for this patient, I planned temporary crowns, and then possibility the orthodontic treatment without pain, and with a patient more motivated for this time of treatment. So next, please. And then I planned some temporary crowns in a digital workflow, and we planned together with the orthodontic treatment how we will could we get better positions or better temporary crowns for this orthodontic movement. And here I used OccluSense to deliver for this patient in this phase of treatment a better balanced occlusion as possible. Because remember that I need space in the front teeth for this movement that were needed. But it's very important to the establish of these temporary crowns a minimum balance between the sides. Then I initiated the refinement of this occlusion distribution with normal papers, occlusal papers, and then I used OccluSense to refine and to get a better balance between the sides. Look that we don't have a perfect distribution, yes, because here it's an orthodontic treatment and with some specific spaces to do this movement, but I need to reach a better balanced occlusion distribution between the sides. So I have OccluSense to help me and to see this distribution and to decide which contacts I need to adjust to get this result. Next. And here we have the final result of this treatment, this complete treatment after prosthodontic treatment, orthodontic treatment, and definitive crowns in place. And once again, I started the occlusal adjustment with papers, normal papers. And then when I say, okay, I'm fine, then I used OccluSense to help me to check if I'm really in the right place with the right balance. And in this case, I have checked before with shim stock the space in the front teeth, and I didn't have contact between the incisors. And when I used the OccluSense, I could find a good balance between the posterior teeth's occlusion distribution, but I also have detected anterior contact that this in specific case is not allowed. Why not? Because if you remember, this patient had a very serious periodontal disease in the distals of this incisor, this central number 1 here, number 11 here, the right side. And I'm not allowed to leave this contact here in this teeth. Since if we have a bone loss, we need to take care a little bit more of this region with a slighter contact. So the OccluSense had diagnosed this contact that I couldn't be able to do with shim stock or normal papers. And the next, please. And here we have the condition, the occlusion distribution in the provisional phase before orthodontic treatment, and here the distribution at the final of the treatment, that where we have a very balanced distribution and very equal intensity of the contacts between the back teeth. And next, please. And last July, I had the opportunity to control this case. It's a 1-year control, and we have the stable contacts 1 year after with a very good distribution and very well follow-up for this case in oral rehabilitation. This is what I have to show you. I have used in many other clinical situations, but in complex oral rehabilitation treatment, it's really helpful to take some decisions and deliver a very balanced occlusion. And now I would like to show you some specific comparisons between the digital tools that we have used. So I started in the digital workflow with OccluSense in 2019, and there I improved with this device very much my communication with my patients. And after this beginning with OccluSense, I introduced many other digital devices in my routine, and it was very interesting to understand how these different tools deliver the occlusal contacts for us. And in this new workflow that we have worked, it's very important to understand the difference and how we can combine the information that these different tools deliver us. And here I would like to show you how we can compare these informations and put all together to get better results with this new workflow. And here I have an occlusal analysis in RP, reference position, with the first contact in a software in Mesh Mixer. And we use a digital facial ball to transfer this position and to make this analyze. And here I got the first contact. And this contact that it's showed here, it's the contact where I really have contact between the meshes, between the teeth. And I can reproduce this same position and the same contact with a scan, where I can see only this first contact. What happens is that the scan give me the option to activate the occlusogram. And here starts the confusion for this workflow. Many dentists tell me that, okay, which are really contacts here and which are not? And we need to understand how to interpret this data that the occlusograms from scans represent. So here in this case, it changes, each color of this occlusogram is a range of distance between the meshes. And it's not the contact or the intensity of the contacts, it's the distance of these meshes. And here it's an image from iTero, and here I have orange contacts that is 0. These meshes are really in contact. I have a really contact between the teeth in this situation that I registered. And the orange contact, the orange images are the space between that range between 0.01 until 0.2 millimeters between the meshes. So I have a very wide information with this color. And with yellow, it's from up to 0.4, and with light blue, it's 0.6, and dark blue, it's 0.8. And so I like to compare these colors and this distribution like when we use carbons or papers in the mouth. If I use a shim stock paper that has 12 micrometers of thin, where I have contact between the teeth, I will not able to pass this paper through these teeth. But if I go to the orange region where it's marked on occlusogram in the scan, if I put a shim stock paper there, I will able to pass this paper through these teeth. But in the same region, if I take a paper with 200 or 100 micrometer of thin, maybe I will not be able to pass this paper through. So it depends. It's the distance, but in the mouth, it depends. The contact that we are able to see depends on the thin of the paper that we are using. And here, with the scans, we don't have these informations to see a real contact between the teeth, since the distance between the meshes. This is very important. And here, when I registered this contact, I register with a muscle activity, and so I can register different. If I do this different times, this can change if I have more or less muscle activity, and so this is very important to understand. And let's check what happens when we use OccluSense. Next, please. Here I have the same situation registered with OccluSense, where I can, which is the difference? OccluSense registers a dynamic occlusion. It's not a static occlusion, it's not a frame from this occlusion, and this is very important. I'm able to find the same frame that I register with scan in OccluSense, yes, but OccluSense delivers and gives us more information than only a static position. It's not what is really happening with this patient, with this system, since it shows us the first contact and how these contacts are changing when I have the muscle activity. This is very rich and very helpful to understand how the system is working. When I use any other digital device, I'm not able to understand and to capture this information. Since if you work with scans, they can improve, the informations can improve with the information from OccluSense, because you get more information in a dynamic way that the scans and the software are not able to give you. And next, please. We can compare what we find with scans, the occlusogram scan, and what we find in a frame from this same frame with OccluSense. And if you see here, if you look here, we can see the first contact that has more intensity here in the molar, but in the orange color in the occlusogram, we have a contact that has a lighter intensity, a softer intensity, and we can make this as this comparison between what the data that we find. Next, please. And here, once more, I can use papers to check these movements and how the patients reach the maximum intercuspal position, for example. Yes, here I have a video, and but when I register this maximum intercuspal position with scan, it's a frame, it's a photograph from this moment, and I get the information from one side, and I need to change and to get the information from the other side. And the force, the strength that the muscles have between one side registration and the other side registration, it's not the same. But when I do this registration with OccluSense, here we have a video. Can you pass through, please? We can check this information here upper. We have the same frame that we capture with the scan, but here lower we have the dynamic registration from this bite, and we can see that now I see that it doesn't happen directly. I have many contacts changing these patients reach the maximum intercuspal position. And sometimes we can diagnose some sensitivity, some pain, some crack with this intensity and this information during the dynamic analyze. So it's all. Thank you.
Thank you very much, Dr. Ebeling, for your very informative presentation and the cases you've presented to us today. And again, thank you to all three of you for your work today and all the work with the OccluSense as well, and sharing your experiences with us. I actually have a few questions I would also like to ask and find out your feedback on them. So I'd like to treat this as an open discussion, so I invite you all to ask any questions that you have and ask any questions about my questions. So the first thing I would love to know is what your first contact with digital occlusion and the OccluSense is, and which other types and foils you usually use in your dental practice. So we already heard for a couple of instances shim stock foil, the normal foil, but for what treatment, which foils you would recommend and what you usually use. So I will start with maybe Mr. Seuser, if you have some feedback.
My first contact was that as I see that OccluSense is a very fine thing to do these occlusogram things with a much better documentation.
Absolutely.
So
yeah.
that was the first thing that I come in contact with that. Yeah.
So documentation we've heard a lot of times.
Yeah, that's a very important thing today. And of course, if you do more complicated cases, it's very important to have in some stadiums, in some states, you have the documentation how it's going on.
Absolutely.
And this is the main thing that I went to this digital advice. But very quickly I recognized that, as I showed it, that it's very helpful to take a look on each patient before you start any treatment.
Even when they think they're very healthy, yes.
Yeah.
Absolutely, yes, definitely. Anything to add from your side, Dr. Wig?
What Dr. Seuser just pointed out, absolutely bang on. So from my side, I normally, as I said, I love to use it, the pre and the post, so that the best thing what I see with OccluSense is I can really see. I can visualize what's happening. So it's going to give me the point contacts and then the difference in the contact levels. That's how the red, green, yellow, orange, those marks are there. So it allows me to understand the pressure differences between each tooth, each contact, and how much to calibrate. So that makes my life easy. When we have been using foils, the articulating papers, since ages.
Yes.
Now tell me something. When you ask the patient after a restoration, can be direct, can be indirect, you ask the patient to bite first, static, and then we ask them to laterotrusive movements and all. So we have those blue marks or the red mark maybe here, here, here on the occlusal surface. Now we grind. Then we ask the patient to bite again. Now, do you know what was the first point? Do you have any record of it? No. No. So then the third bite, then the fourth bite, it continues on and on, but we do not know my first starting point. So this gives me the first point, and I can also compare. I can put the two recordings on the same screen. It allows me to see what was first and what's happening after I have done the work. So it's, as Dr. Seuser also said, it's beautiful documentation. The patients can see, and that's kept in our record for posterity. And we can convert it into JPEG, video, PNG, and just store it. And if the patient wants it, we can give it out. So it becomes a fantastic tool for us.
Yeah. Of course, we can use this tool also if we're doing some reconstruction cases. Yeah? And of course, we can use it if we do some functional treatments. And so I have one last case report here showing this on which points of this functional treatment we can use this. Yeah? So these are the photos of a patient that came to us with very severe clicking in the left joint. Yeah? He can't open his mouth more than 2 centimeters, and then this very strong clicking appears. He had some muscle problems and so on. This is the main reason because he's coming to us. So as we take a look in the OccluSense protocol, this is not so bad. As we've seen here, this is pretty nice ICP, we should think. Left and right side, not so much contacts in the front. It's pretty nice. If we take a look on protrusion, it also not so bad. On the lateral protrusion movements, we had some pre-contacts in the back area. But if we take a look at that state on the OccluSense protocol, it seems to be not so bad. There seems to be a nice ICP. Everything is fine in that state. But the patient had all signs of screening tests here. He had this clicking, he had his mouth opening is not wide enough, he had a deviation to the left side, he had painful muscles, and also the excursive balance is disturbed, and it's an irregular closing sound by that. So we had to go for more diagnostic, and this is the normal way we use to have this functional diagnostic in this way Professor Slavicek taught us. Of course, we have first an initial diagnosis, then especially functional diagnosis. In the initial diagnosis, we can use OccluSense, but in this case, it's not so helpful. What's going wrong, we find out with all the other tools that we have in our functional diagnostic. we are using clinical examination. We are using these Brax checker foils, and we can see what the grinding movements in the night. We do a condylography, we do a lateral ceph analysis, and then we can, here this is one part of his, this is the clicking here on this part of the condylography, and then we can create another position for that patient. We can create another position in that case. Yeah, we have in the gamma system we have this so-called positioner, and we can calibrate a new position for the lower jaw. Yeah, and that's his first bite situation. Yeah, and this is the situation if we put it in a joint-related position. Yeah, it's very great difference here in this area. And then we're doing a splint. Yeah, we're doing a 24-hour splint here in this case. And here once again, this is the initial ICP on the OccluSense protocol. Not that bad, here a little bit less, but not that bad. This is the splint position, yeah? But we have a totally different position of the lower jaw. Yeah, so we see both seems to be equal, but we have to think about what position do we have, what we're measuring with that OccluSense protocol now. But this is a very helpful thing, and now this is the way going from the ICP position in our therapeutic position. We do a wax up, we do the preparation, and then we can do the reconstruction. And so this is again in this process the wax up for the reconstruction, and this is what we do together with our technicians. We try to use OccluSense in the articulator, yeah, to see what's going on there, yeah. And we can see here that we had first this arrangement here, yeah, and we do a little bit here on this tooth. We reduce a little bit, and we have this here, yeah. And still a little bit too much here in this area, yeah. But these are natural teeth, and so we just like to take a look first, yeah, what's to do. But as we check it, if we put the total, the definite reconstruction in, we have the same here in the mouth. That's very interesting. We can have it in the articulator and the same thing in the mouth there. So we can use this, of course, to check up everything, and of course the final reconstruction to take a look if that what we have done is working, yeah, because we don't have to, of course we don't have to treat only this joint and muscle problems. We have to fit a new occlusion there, yeah. And on this points, OccluSense, if we know what position we are measuring, yeah, is very helpful to take a look on. Yeah. Okay.
Thank you so much. A lovely addition again, just to complete everything we've had talked about before. What kind of treatments would you say could you not do without OccluSense, or what do you use it mostly for?
I think you just have to think over what you are measuring. Yeah, mm-hmm. That's the only fact. You just have to think over what you see. Yeah, and as I told it, if you have some teeth, yeah, that don't give you so much pressure, yeah, you have to think about. Yeah, that's the main thing you have to do, and you must think about if is this ICP, is this a splint position, yeah, is this another position? Yeah. You can use it in every case, yeah, but you have to think over what do I see here.
Let me allow to say that maybe this is for advanced people that literally know how the OccluSense work, and they can identify which treatment do I need it for. But maybe for a beginner who hasn't used it before, do you have a recommendation? What kind of treatment would be a good one to start off with, so they can kind of try it out for themselves and understand it a little bit more?
yeah, I think this first view, yeah, I think this would be the best, yeah, because you don't have to do something.
So for the initial diagnosis,
you can only diagnose this, yeah, you can think about what's going on here, yeah, and maybe you find out, yeah, like I did it, oh, this tooth is a little bit weak, yeah, and that might be the reason because this column is not so high, yeah. So this is, I think, the best way to go through it, yeah, to take a look on it, yeah, and of course I'm trained by this protocol of Professor Slavicek, yeah. You can, and so I always do these 5 movements, yeah, but you can do this in one sequence, of course.
Yes.
Yeah, you can change to 10 seconds, yeah, and that's enough time to let patient close, go forward, backward, left side, right side, yeah, and you have all in one. Yeah. This is 10 seconds, yeah, for the first appointment, and I think this is very fine to take a look on and to come in this
workflow, yeah.
In this workflow, yeah.
Absolutely. Thank you very much. Yes, I'm going to pass the question on to the ladies as well. So, is there any kind of treatment that you feel would be a good one to start off with, where you say, "This is I know that this type of treatment, I'm going to grab my OccluSense and go and have a look what the occlusion looks like," for example. Maybe Dr. Wig?
Restorations.
Yes, okay.
It can be indirect, it can be direct, but that's where we are changing the cuspal and occlusal surface. That's our play field there. So once we do that, I should know what we started with and what is exactly the balance we are going to give.
Yeah.
So restorative procedures, orthodontics. Orthodontics, the complete teeth are shifting.
Yes,
there's a change in the bite, there's a change in occlusion. And that's another way. So I can't perio. Like he pointed out, the patient was so happy, I have no complaint.
Yeah.
But when you looked at OccluSense, it gave you 3-4 places to see, exactly check. So again, for me, it is kind of every treatment in routine dentistry except maybe surgery. I won't use it in surgery, but apart from that, all other specialities do need balancing. Without occlusion, how can you give a stable restoration of any kind, for that matter? Any kind. It won't last.
Absolutely, yes.
So that is how I look at it. It's the need. For me, it's like routine.
Yes.
Like I use my microscope, I use my loupes. Whatever extra we take after 3-4 years, we love to add on to the practices, right? Everybody of us does. Start to beginning. So this is a good tool which helps me keep the documentation, makes the patient see, makes the patient's family see, and they are really like, wow. So that's what, you know, yeah, that's a good communicating tool, and it helps me balance them better. So I have a long-lasting relationship with them because I know my restorations ain't going to fail, because now I have seen what I'm going to do there. You know, so it helps me big time.
I would love to talk a little bit more about the reactions of the patients that they give you when they see a digitalized occlusion and they are able to kind of have a look inside the mouth, like you said. So do you have any more experiences? Maybe Dr. Ebeling, is there any experiences that you want to share with us about patient reactions when they look at OccluSense?
Yes. As I told you, I started to in a digital way with OccluSense, and it improved a lot my communication with this patient. And what improved is that the patients are able to see what we are explaining, and when they see, they can feel. And they go back to the movement and they can understand, yes, I have this content and it is in this exactly point that I have feeling, that I have pain, and yes, I feel this comfortable during my mastigation function or so. They are able to understand what we are explaining. And as Dr. Rumpa said, we are able to documentate these situations and show them to the patients that we improve it, or if we are doing some control, if what is happening. So we have very, very understandable information to show to these patients and improve our communication with them.
Absolutely, yes. Thank you very much. We've heard within our patient cases a couple of points about the algorithm that is used. So in what way OccluSense is used next to the papers. So Dr. Ebeling mentioned that she actually checks the occlusion with the papers first and does fine adjustments with OccluSense. We also have heard about using OccluSense first to give you a better overview of all the pressure distributions in the entire occlusion. So maybe we can talk about what kind of algorithm is recommendable, or do you think both is maybe an option? Do you have any experiences with that? So in which order OccluSense should be used next to the papers?
Papers can't do without. Definitely, they are a very necessary tool, but as I said, I have developed into my practice by starting first with occlusions before I start any of the treatment. And then I check the post, and before the post, occlusions comes in my articulating papers. Just to have the little, where I'm doing the calibration, how am I doing it, what kind of burr do I need to use? Do I need to use a ball-shaped burr or a tapered burr? So that gives me an incline as to what I need to do. And then the final, of course, is with OccluSense. And then I can check my pre and post on the same page. So that gives me, and of course the patients, like, okay, this were. And I love explaining them the red, green, yellow and orange when this is what it's depicting. They understand.
They love colors.
They love color and they understand. Okay, so it's like one of my patients told me, red means you got to stop at a traffic signal. I said, yes. And green means you go. I said, bang on, yes. So that's how easy it is. So they understand that concept. Red is okay, I need to work on it. But green, yellow, orange are good to go. We are comfy. So they take that pretty well.
Yes. Thank you so much.
Most welcome. Anytime.
Do we have any open questions from our listeners today?
Yeah, I do have a question. Thank you, of course, very much for all this kind of presentation. To Rumpa, Dr. Seuser, to Juliana, and of course moderation. So my name is Peter Bausch. So I'm also responsible for the scientific part and product development in the company. And I also work very close together with Professor Sanata. So we do a lot of, researching, and we have been visiting the Gamma, the wizard school, the summer school in Vienna. And we also developed this thing to combination like you do with the waxes. I think it's a very good tool to use both OccluSense and the Occlusogram wax. We are now manufacturing those kind of waxes for the wizard group and probably will offer a similar device for everybody. Anyway, what I think is important, I've seen in your case, Dr. Seuser, you're patient number 2 case, there was a rocking teeth. I saw a massive hyperbalance on the meditrusion side. Did this have any influence? The meditrusion contact, patient number 2, on the OccluSense screen.
Of course. Of course.
Yeah.
It will. This is what you see on the OccluSense, and what you might pass if you use only papers.
So it's definitely a very, very good tool to visualize. And I also love the analogy of it's not occlusion, it's occluding. So it's a process over time that is happening. And we don't just want to see the final position, we want to also understand what is happening before all of that. So yes, definitely. Is there any more questions?
My name is Werner. I'm working as a lab manager here in Köln.
Hi.
So my question is there a link between OccluSense as an information tool which you can transfer into your dental lab, that the guys there can use this information, ideally digitally, which probably not yet works. But how do you share this information with your technician?
Of course, you can share the videos, to the laboratory. What's going on? If you do this, and we try to do some things, as I show it here, to use OccluSense also in the articulator. I'm trying with my laboratory to do that. So maybe we have one thing we checked. We do one crown, and we check with the OccluSense before preparation, after preparation, then models in the articulator, also, and then the wax situation in the articulator, so we can use it, I think, also with an articulator.
So you can use it in the articulator, and for example, you do a diagnostic wax up, and then you use OccluSense and can transfer. That makes sense. The height of the pillars you see in red, for example, is that related to a certain amount of pressure?
To the power. If you have very high columns, you have much pressure.
Makes sense. How do you transfer then if you pre-treatment, let's say you do a splint or whatever you want to do? So how do you transfer this information? You have it visually on your iPad. How do you transfer this specific point into your patient's mouth if you want to adjust the occlusion? Is there any way of transferring this, or is it just the spot which leaves like an occlusion paper on this tooth, what you can then visualize on your iPad and see, okay, this one is really high, I need to do something. Is that like this?
First thing, the foils are also with red color. If you use it in the patient's mouth, you see the context pretty good.
So you can do it straight away? Okay. Oh, cool. Thank you.
Ja, eine Frage. Professor Slavicek hat uns ja gelehrt, schaut in den Mund, dann wisst ihr, was los ist, in die Okklusion. Schlifffacetten, Abrasionen, Hyperbalancen. Das System gibt mir doch nur einen kleinen Baustein in der Diagnostik.
Natürlich, klar.
Und meine Frage, das ist ja gerade schon beantwortet worden, die Kraft spielt überhaupt keine Rolle, wie fest oder wie schwach ich zubeiße. Es gibt mir ja unterschiedliche Werte an. Und die eigentliche Frage, was ist bei Teilprothesenträgern oder bei Totalprothesenträgern? Wir haben ja hier nur Bezahnte gesehen. Wie funktioniert das System dort? Und welche diagnostischen Möglichkeiten gibt es mir? Beispielsweise bei Totalprothesenträgern.
Okay.
So the question is that OccluSense gives you, doesn't have to give you a pressure overview in a number, because it doesn't matter how hard the patient bites, it gives you an overall overview which is objective. So in an overall overview, yes. And also a question is how would it be with partial prosthesis and total denture people? So the partial denture and the total denture patients, how it would work then?
I actually showed a case of the partial denture.
Oh.
Right. My case 1 was that. It has a Kennedy's class 1 and then I fitted it with the denture. It works. You got to try it out, it's beautiful.
Also der erste Fall, der gezeigt worden ist, da war tatsächlich eine Teilprothese mit dabei und es funktioniert.
I think there was another question about edentulous cases. Is that right? Weil über Totalprothetika auch wollten Sie wissen. I think there was another question about edentulous cases. If you can use this information for edentulous cases as well.
So the total dentures. If anyone has any experiences.
Does it make any sense do you get any information out of this if you have edentulous patients with full denture?
Nothing, The pre will not give me anything.
Oh,
the pre-scene without the edentulous complete area will not give me any registration. Right. And the post, normally we try to balance it out. But since I have not worked on a full denture case as yet, so I will try out something and I will answer that question for you.
Thank you. Thank you. I was just repeating the question of that gentleman.
Sure. Thank you, because this opens up more horizons for us to work.
Probably.
Yes.
Okay, thank you.
Thank you for that question and thank you for the explanation. Thank you.
then we thank everyone so much for your feedback today and taking the time to also listen to us. And yes, I'd say we'd give a last round of applause. Thank you so much.